I'm Armen Kelikian. I'm a orthopedic surgeon from Chicago, and I'm a professor of orthopedic surgery at Northwestern University Medical Center, and I've been in practice about 40 years. I'm going to talk about tibial plafond fractures or pilon fractures, or whichever way you want to call it. We usually say pilon in this country. These are different from simple ankle fractures. They're a totally different animal, and the treatment's totally different. I can't advance this thing. Okay. I do have some conflicts. Some of the slides are out of these books that I've authored or co-authored, and I'm a consultant for some orthopedic companies. Getting into plafond fractures, they're unlike regular ankle fractures, which would be the medial or lateral malleolus. These are not rotational injuries. They're more axial load, like a pillar on a ceiling. This is a French term, pilon, and it's a noun. It's a mortar and a pestle, and that would be the talus, which would be the pilon, and it jams into the roof, which would be the distal tibia. Again, it's more of an axial load than anything else. So on your left, you see a simple bimalleolar ankle fracture, and on the right, you see a comminuted distal tibia fracture. They are both ankle fractures, but they're both totally different, like night and day. This is not an ankle fracture. These things, usually at this point in this country, at least, because they're high energy, high velocity motor vehicle and falls type of trauma rather than rotational injury from sports, are treated temporarily in an external fixator. When you look at outcome studies of different diseases, everything from asthma to pelvic fractures to spinal cord injury, you can see pilon fractures are fairly devastating on what effect they have on a person's life. It's almost up there with spinal cord injuries. It's more than multiple trauma or diabetes or heart disease or AIDS. In the old days, this is one of my father's slides. This is in the 1960s. We would actually put pins in the leg, in the heel, and in the tibia, and put them in a cast and just try to get them stretched out to length and just deal with the consequences of the problem years later when they need reconstructive surgery, say a fusion or something like that. This has changed. The most common classification, which I really personally don't like, is the Swiss classification of Rudy and Allgauer. And it talks about type 1, 2, and 3, depending on the amount of comminution. When I trained, we swore by this. This is the Bible. And these were mostly ski injuries, boot top injuries, things like that. They weren't the devastating injuries as you see in the type 3 on your right. And it was taught to us based on the Swiss experience that you should operate on these right away. The ones on the right that you see that are fairly comminuted, it would be a big mistake to operate on right away, unless you want to end up with an infection or an amputation, because the soft tissue problem is the biggest complication with these injuries. So you don't operate on these right away. You do put them in a spanning fixator, you get them out to length, and I'll go through that. And you wait 2 or 3 weeks till the soft tissue allows you to operate on them if you need to do surgery. This is the AO classification. It's a little more intricate. They base this on location of the extremity. A 4 would be the tibia. 3 would be how far away it is, would be distal tibia. A 1 would be near the knee. Then they have extra-articular fractures, they have A1. They don't involve the joint. These can be treated with a plate or a nail. Any of these you see, depending on the comminution. Most people would probably plate the 2 and 3. The B fractures are involved in the joint. They can be the anterior pillar, the posterior pillar, posterior malleolus, an intra-articular medial malleolus fracture that you see on B2, or a Chaput fracture, which is the anterior lateral corner on a B1. Those are fairly simple. Those you can operate on right away. the ones that are the problem are the C fractures. There's simple ones where they're big pieces. That's a C1. As it gets more complex, the number goes up, C2. And when they're blown apart on the bottom right, you can see this C3. And these injuries probably need a little bit time to incubate and to get right before you operate on them. This is an example of a extra articular fracture. So it would be A, it's not in the joint. It was treated temporarily with pins and then exchanged for a bunch of screws. This is about 35 years ago. It could have been plated. It's a low energy injury and it's more rotational. There's large fragments and minimal involvement of the soft tissue because there's not a crush. So this is pretty straightforward stuff. This is more like you'd see after a ski accident. This is an example of a boot top injury from skiing, and you can see it's displaced. This is something you could treat in a fixator, you could treat with a rod, you could treat it with a plate. It's really the dealer's choice on this one. So these are, even in the Pilon fractures, there's differences in the degree of involvement, whether the joint's involved or not, whether they're big pieces or small pieces. This is a distal tibia 4-3 C2 fracture, fairly common. You can see there's an articular fragment here that's flipped up in the central area, and this is a CAT scan after reduction. So your goals, these are the goals of the Swiss. So the goals, they had great ideas. Alignment is important, length is important, articular restoration. You want a foot that can get on the floor flat, plantigrade. You want to minimize the degree of soft tissue compromise and need for open manipulation. And if there's a big defect in the metaphyseal area above the joint, bone grafting. The problem again was when I trained, this was the standard of care to operate on these bad injuries right away. And the complication rate in this country, in the United States, was up to 45, 50%. It's not because we're not intelligent. It's not because we're bad surgeons. It's we were applying the principles from the ski slope to motor vehicle accidents, falls, and heavy duty trauma, which is probably what you see in your country as well. I don't think there's skiing out there. And we took what they taught us and we tried to apply it to our population, and the complications were devastating. Amputation rate, infection. So then in the late 70s, people came out with delayed treatment for these fractures. They'd wait up to 2 or 3 weeks. They'd have them in external frames, let the soft tissue injury go down, and then stage it and do the open surgery if needed 2 or 3 weeks later when the foot was ripe, not when it was swollen. And these are the studies from 1999 at major institutions where the infection rate dropped from 50 to 3%. The complication rates dropped from 55 to 0%. And most people waited 2 to 3 weeks for the treatment. So when you do treat them, you want to repair the fibula, you want to reconstruct the joint, you want a bone graft if necessary. That's an example of that case up in the corner of one I did in the when I first started in 1980, and I plated it right away and did this. And basically, we'd say the Swiss treatment is not for my generation; it should be for my parents' generation. The way we did things, and I'll keep showing that picture. You'll see why. Again, you want to look at the patient too. Polytrauma. What else is going on? Smoking is not good for this. Tobacco is not good for this. This guy smokes 2 packs of cigarettes and drinks a lot of alcohol. Not the best patient to operate on, and it's something you can control to some degree by counseling the patient about tobacco. This is the complication rates I was telling you about: 70%, 50%, 54%. And then you can see in the last one, Oviated and Beals, when they operated on their type 3 fractures, they were getting 10% wound complications and 6% osteomyelitis, which is an example below. This is that patient I kept showing you with the plate that got infected. He had a methicillin-resistant Staph aureus. I had to take the plate out. 2 years into practice, he had to have a local flap, and he avoided an amputation. But if I would have waited 2 or 3 weeks, I would have never had this problem. He'd never have that leg like it looks at this point. Now, we use this, the old standard, which I was talking about, is not the gold standard. And think of the bone as a banana, and then think of the soft tissue as the peel of the banana. And you have to respect the peel. The tissue is the issue when you're talking about these fractures. So now most treatment for the type C fractures are staged. Initially in the emergency room, that day you put them in an external fixator, you get them out to length, and you delay the surgery. You wait 2-3 weeks, come back and do the appropriate surgery. So we're going to get into that at this point. But I just wanted to give you the history. We call it traveling traction. This is very simple. In any country, you put a pin in the heel, a pin in the tibia, and you get them out to length. There's no point in getting a CAT scan or a tomogram till after you have it reduced, because it's not going to give you good information. And you want to span the joint, and it will not reduce the joint fragments, but it will get the alignment of the metaphysis and the tibia. Now, in America, there was disco music in the 60s, and it's not very popular anymore. And I don't think immediate open reduction is popular. Disco is dead, and so should be open reduction early. We have different type of plates for, we can use percutaneously. You can use lock plates, not lock plates, depending on the bone quality. External fixation, such as circular frames and Lizroff, that I'll show you as options for your definitive management. This is a temporary fixation with a fixator and then wires. There's a lot of different things available. We even do arthroscopy sometimes, depending on what you have available to yourself. The most important thing is preoperative planning. You have to look at the soft tissue. You have to look at the fracture. Is it out to length? Is the alignment good? Is there articular or joint impaction? Is there deformity, varus or valgus? And the varus or valgus deformity will tell you where the comminution is. If it's a varus deformity, you usually have comminution medially, tension laterally, and you're going to put a buttress plate on the medial side, on the compression side. If you have a valgus injury, it's the opposite. You're going to put your plate anterior laterally on the compression side. So you buttress the compression side. Very important principle. Here's an example. This is a varus deform. This is a medial compression, and this one needed a anterior and medial plates. Here's an example. I'm sorry. This is the varus compression. So there's tension on the lateral side. The fibula is bent, and there's compression on the medial side. So you put a buttress plate on medially to get this out to length on the compression side. Conversely, for the valgus injury, the CAT scan here, you can see what's involved. You can see that you have an anterior lateral fragment on 5 anteriorly. The fibula is a small area, the small bone. You have an impacted fragment in number 3. It's flipped up. It's a central fragment. You have the posterior malleolus in number 1, and then you have the anterior tuberosity, or the medial side in number 2. So number 5 is your anterior lateral fragment, number 4 is your medial fragment, number 1 is your posterior fragment, and number 3 is the impacted fragment. This will give you an idea of a window where you make your incisions to fix this. This one you probably have to go anterior to fix this, and you want to fix everything to number 1, the posterior side. So you have to have a plan before you go in the operating room. You can't drive a car in the middle of nowhere and not know where you're going. So you have to have a route. There's all these types of things available, different types of plates, different shapes. We don't have them in all countries, but these are the various things available for you. Fixators, plates, so forth and so on. This is a percutaneous plate, which was slid up. You don't have to expose it this much, and buttressing the medial side. You can do this through small incisions if you're lying well. Here's examples of little devices we have available here where we can put these different plates on. On the bottom right, you see the anterior lateral plate. On the bottom left, you see the medial plate. This is the comminuted fracture above in the upper left-hand corner. Now I'm going to show you some cases. Here's a 13-year-old was playing baseball. It's a sport where you run and you slide. Like someone after they play soccer, they score a goal, they slide. And you can see it's an intra-articular fracture. It's a growth plate injury. triplane fracture. This is not, it is a pilon, but it's a simple one where you can just use screws. And here you see the fracture on the CAT scan. You can see the different fragments, the anterolateral fragment, the medial fragment. And with simple reduction methods, sometimes with something like an arthroscope, you can go in there and reduce this and fix it. You don't have to open the whole thing up. It depends what you have available. So I took an arthroscope. I cleaned this up about 20 years ago, reduced the fracture, looked at it with x-ray as well, and then just put in 2 screws. And that was it. This is a simple injury, not a lot of morbidity, doesn't require delay in surgery. This woman walked in my office, walked in my RER, not walked in, had a car accident and had this C2 type fracture of the distal tibia, pretty comminuted. And I knew I had to put her in a frame. So I put her in a frame in the operating room. This is 2004. And all of a sudden everything came out to length. And I said, okay, well, maybe I'll just shoot some screws in here. Maybe I'll never operate on her. And here she is at 5 years. She has a little arthritis. She's healed. Here she is at 12 years. Still looks good. Little arthritis. Here's her range of motion, 20 degrees. Here she is just a month ago. I saw her for something else. She has valgus knees. She's had total knee replacements. Her ankle still doesn't bother her too much. Bothers me, but it doesn't bother her. And you can see she's lined up on her mechanical axis and has minimal pain. And I got away with not doing a big operation with simple surgery. I got lucky. And here's her walking in my hallway.
This is a miracle to me. He put this in 30 years ago and it hasn't been replaced.
Well, it was 30 years ago, not 17. I'm sorry. And there she is walking, little limp, but not bad. And she's happy. And that's her x-ray just last week. The x-ray doesn't look good, but the patient looks good. Now, this is I borrowed this from one of my former residents, Jeff Earhart. Fairly extensive fracture. This is a different fracture. It's a type C3. It's the worst you can have. He waited 2 weeks. Then he opened it up. You can see the joint surface where the freer is on the right, and went ahead and fixed all this. And that's how it looks. The compression side was laterally, so they put an anterolateral plate and a buttress plate also medially, and it looks amazing. So these high energy injuries, type 3s, it's been broken down more by other people, Oviedo and Beals, but these are the bad actors and the bad patients. Here's some examples of some simpler fractures. Patient fell down the stairs. It looks like a simple fracture, bimalleolar, but it's not a bimalleolar. You can see a shadow in the back. It's a trimalleolar, and it's really a posterior pilon fracture. When I trained, we didn't fix the posterior pillar. We fix it mostly all the time now in these ankle fractures. This is a variant of the plafond fracture. And there's some very good articles out of Switzerland about this. When you see this double density on the arrow on your x-ray, something's broken in the back. And they can be in one piece or 2 pieces. There's a classification system for this. Type 1s are pretty simple, a little piece off the back. Some people don't fix those. Type 2, it's 2 separate pieces. The posterior tib fib ligament is attached to this. There's a transverse and intermillular ligament. And then there's a type 3, which is a large fragment. Now, the standard training when I trained was if it's less than 25% of the joint surface, leave it alone. That's not true because a ligament attaches to it and there's instability of the joint long term. And you can see that both the type 2s and 3s can be bad injuries. And I consider these pilon variants of the posterior pilon. How do you approach these? Do you go front? Do you go back? The best way for me is prone on their stomach, and we reduce the posterior malleolus first. Then we reduce the fibula. You're upside down. And if you have to go medial, you can flip them over or do that side. This fracture you can do within the first week or 2. You don't have to treat them with a fixator, but you can and wait. So fix the posterior malleolus first, because if you fix the lateral malleolus first, you can't see. The CAT scan is very helpful here. It gives you a plan of where to go. And this bone is attached to the posterior tib fib ligament, which is probably 42% of the syndesmotic stability. So here we go. We put 2 little screws in the fibula, not a plate. to hold it. We put the posterior plate on after we reduced it, and we reduced it extra articular. This ligament has been shown to be 42% of the strength of syndesmosis, and it does not necessarily need syndesmotic fixation like with a screw through tib fib. Here's an example of the posterior lateral approach. We make an incision just off the fibula, and the interval is between the peroneus longus and the flexor hallucis longus tendon, which is seen right here. Okay, and right now I'm on the distal tibia, and I put a retractor underneath the flexor muscle, move that with the neurovascular bundle medially. And here's my fixation. I still stressed it afterwards. I did have to use a syndesmotic suture. Some people use a screw, and I did a bridge plate on the fibula. Another case, same thing. Posterior malfracture. This is a type 1 with a medial malleolus comminuted fracture. First, we put the plate on in the back. Then we put the plate on laterally. Patient's prone. This looks like a right ankle, but it's upside down because the patient's prone. And then we fix the medial malleolus with this sophisticated sled. And patient did very well. It's the left ankle. Now the patient's not upside down. And you can see the range of motion is good and so forth. Another case, 38-year-old slipped falling with kids. I don't say if him or her anymore, and had ankle pain. Went to a local hospital. You can see the posterior malleolus. You can see the crescent sign here. You can see the spike here, and you can see the fibula is broken as well. So we waited. We got this out to length. And in the ER, they tried to reduce it. Finally got it reduced, so we didn't have to do a fixator here. You can see there's an impacted fragment in the joint, so it's kind of like a Pilon fracture. You can see the medial size comminuted. You can see the posterior malleolus, medial and lateral, and an impaction die punch piece. And there it is with the arrow there on the axial view. This is a type 2 because there's 2 pieces, and there's the piece. So I approach this posterior medial because there's more action medially. And that's between the FHL, flexor hallucis, and the Achilles. And here's the portal. These are different diagrams showing you how to approach these. Here's your posterior lateral incision, posterior medial. This one's a little risky, but you have to be careful in your dissection. You have to know your cross-sectional anatomy. Here's the different portals, how we do it. This is an excellent review article in the Journal of Trauma, and I think all the residents should be looking at this. Here's your posterior lateral that I showed you on the first case, and between the peroneals and the flexor. Here's the posterior medial between the neurovascular bundle and the FHL. And this is showing you the different windows. This is the posterior lateral window, posterior medial window. You get great exposure to the posterior tibia. This is a fun operation, but do this prone. Here's an example of a posterior medial incision for the plating because the fracture was medial. Here's this case that I just showed you. Here's the FHL. It's a big piece of meat, beef towards the heel, and the neurovascular bundle is here. And here's a fracture site that I'm cleaning up. There's the approach, posterior medial approach, patient's upside down. And later I went lateral. Here's my 2 incisions after I fixed it, medial, lateral, and my fixation. I have a T-plate, I have a neutralization plate here, and I have a hook plate here for the medial malleolus. 18-month follow-up, decent range of motion. Another one, we have ice in Chicago in the winter. You can't see it and people fall. We call it black ice. And this is a posterior pylon. You can see it's 2 pieces. And first we fix the posterior piece, then the lateral aspect, and then I put a buttress plate medially. There's no syndesmotic fixation, good range of motion, excellent looking x-rays, and 6-month follow-up, walks fairly well without shoes. So no limp.
Back.
Another one, marked widening of the joint. This is not bone. This is a plaster and a cast in the emergency room. I thought it was bone at first. And you can see the ankle's dislocated. There was a high fibular fracture, Maisonneuve fracture, but a Pilon as well. We tried to reduce it. Here's my CAT scan. You can see it's 2 pieces in the back. And what I did is I was able to reduce it, waited about 10 days, came back and put a T plate in the back, a hook plate here, and then a syndesmotic screws here. This is a rotational injury, but it's comminuted proximally. And if you put sutures, you would lose length. So you have to maintain length with this. You can see the range of motion, so forth. Toboggan injury, a sled. This is a different pattern. This is more anterior pilon. You can see the medial malleolus is part in the joint. There's an anterior chaput as well. CAT scan tells me to go anterior. So I use an anterior approach. Some people do an anterior medial approach. I took out a loose body and I used a medial plate, fibular plate, and I put a syndesmotic staple. Some people would use a screw. I use staples at times to hold the syndesmosis. 7-month follow-up, good range of motion. Fractures are healed. Another one fell off a ladder. This is an anterior pilon. So this is the compression side. So you put your plate anteriorly. It's common sense. Here's your CAT scan. You can see medial malleolus fracture and an anterior malleolus fracture. There's a dye impaction injury. You see the piece of bone here. We did this extensile approach. I use a vertical incision, more or less. This is the article I told you about before, Journal of Trauma. And then hang it up, make the anterior approach, go in there and clean the joint out, put the pieces back, and even bone graft the defect up top. These were loose, dead pieces of bone and cartilage that we took out and threw away. Temporary fixation with the anterior plate. There's what the joint looks like from below, not very good, but aligned up, big plate, and then separate medial incision for the medial malleolus, and ended up with a good functional outcome. Now, I think this is going to appeal to you more. And this Lizaroff was one of the greatest contributions to orthopedics in the last 50 years, coming from a general surgeon in Siberia. And I met him in the 70s. Interesting person, genius. These bad fractures that go into the shaft and worn injuries are probably better treated with the Lizaroff. And it's something you should, I'm sure you know how to do and see a lot of. We don't do it as much in this country anymore, but it's a wonderful procedure. You have to know your cross-sectional anatomy. We use the clamshell techniques, percutaneous techniques, and usually incorporate the foot. This is a case I did about 20 years ago. Comminuted fracture. I was going to open it. The skin wasn't good. I put it in a frame. I did indirect reduction techniques, a lot of K-wires, a lot of clamps, a lot of olive wires. And you put a lot of your pins in line with the tibial crest. You don't want to be in the neurovascular bundles. So you have to know your cross-sectional anatomy. And you can see this is how the patient looked 10 years later, has mild arthritis, but still hasn't had a fusion or an artificial ankle in 20 years and is doing well. There's a lot of advantages. There's disadvantages. If patients don't like them, you can have little problems and access the pin sites and so forth. Here's a patient, a hockey injury, ice hockey. She was playing hockey. It's like soccer, but it's on ice. And she came to the emergency room with this Pilon fracture, one of the worst I've had in the last couple of years. A spine surgeon put this on. You can see the x-rays with it's fairly well reduced, a big posterior piece, and marked comminution laterally. This is a CAT scan in the frame. Gives you an idea what you have to do. So I first, I got the CAT scan. You can see the medial malleolus, the anterior joint, the chaput, anterior lateral, the fibula, the insertia, and the posterior lateral fragment. So this was my constant fragment. So first I went in the back. I used a chandler like a shoehorn, and I put the piece back in place. There's a wire in it. I plated that. I fixed the fibula. Then I turned the patient over like shish kebab and went in the back There's the flexor muscle, the peroneal muscle, and I cleaned the joint out too from the front. And then I put a plate. I've never put more screws and plates in a patient before in my life. Bulky joint dressing afterwards. Here she is, well lined up. She's about 6 years out, has restricted plantar flexion. I'd rather have restricted plantar flexion than dorsiflexion, and walks good with the shoes. And
Come on back.
plays hockey still. And this is a 3-year follow-up. She can walk for you again.
Yep. You're too fast. Come on back.
Okay.
I'm going to show you one more case that's interesting, if it's okay. This is something really important. When you have severe comminution, this is a lady with alcoholic neuropathy that had a pilon fracture treated like this, fell apart, Charcot, fell apart. I saw her after this, and I put a rod in the other leg. She comes in 2 years ago with a simple ankle fracture to a friend of mine, fibular fracture. He put her in a boot, let her weight bear. She saw me 8 days later. I took a stress x-ray, and now she has a pilon fracture. And I got a CAT scan. The fracture got worse. The CAT scan shows now she has a pilon fracture, anterior and posterior. Knowing what happened to her with the other ankle, I didn't want to be in that trap. So I had to do something different. I could use a Lizaroff, but in a neuropathic patient with a bad ankle fracture, the simplest and I think best technique is put a rod in their leg as an internal brace. I can't fix this. I don't know who could fix this and do a good job. This is an article out of Foot and Ankle International from 2 years ago. In diabetic patients, I think they had 18 people that they put a temporary splint in. Look at the fracture here. I don't care how good you are, you can't fix this. You put the rod in, it's an internal splint. That's what I did here. It took 40 minutes. I put a screw in her fibula, put the rod in the bottom of her leg, lock nail. We use long nails on these neuropathic patients, and everything's out to length, and she went ahead and healed this. Eventually, I took out one of the screws so she could compress it, but she didn't need the motion. And if the rod ever bothered her, I'd take it out. That's a 7-week follow-up. Now, last thing. This boy walked in my office Monday. He was in Mexico. He broke his ankle off a bicycle, and they put him in a cast, never reduced it. And now, next week, I'm going to do this. I have a ankle that's dislocated in the back. He's 17 years old. The easiest thing would be to do a fusion, but I want to give him a chance. I'm going to do an osteotomy of the fibula. I'm going to do an osteotomy here. I'm going to go posterior, prone. I'm going to get that talus back into the ankle mortise. Here's the CAT scan. You can see the fracture right here. And I'm going to try to reduce it. I'm going to try this first before I do a fusion. So I got a lot of stuff. I took a lot of time here and talk a lot, but what matters is take your time, be critical of yourself. Stage these things, the bad fractures. Wait about 2 weeks to do it. Have a plan. Where are you going to go? Where are you going to drive your car to? How are you going to get there? Have a plan. That's the CAT scan if you can have a CAT scan. And if it's the side is compressed down, you have to have the buttress plate. So if it's varus injury, buttress medial. If it's a lateral injury, valgus injury, you have a plate laterally. This one had both. There's a lot of complications. You want to avoid amputation. You want to avoid osteomyelitis. And if you do a good job, you want to try to avoid arthritis. We can always do a fusion. We can always do a total ankle. But these are devastating injuries, and they can really affect somebody's life. There was a person, anthropologist named Margaret Mead, and she said the first sign of civilization in a culture is when people help each other. The only good thing about COVID is people are learning to help each other in our country and all the other countries, but helping someone through difficult time is where civilization starts. And if we can't help each other, we can't do anything. She found a person with a broken femur that was healed. In the animal kingdom, you break your leg, you're dead, you're finished, you're going to get eaten up. And hopefully in our society, we've evolved where we can help people that have had these bad injuries. Thank you very much.